All right, thank you everybody for joining us this evening. I want to welcome you to our presentation talking about suicide with Dr. Blaise Aguirre and Dr. Gillian Galen. I am Doreen Heineman. I am the program manager for the Sashbear Foundation. We are a charity in Canada doing work in the field of emotion dysregulation. Today, I'm joined by Lynn Corey, the founder of the Sashbear Foundation, and also by two Sashbear volunteers, Kathleen and Barb, who will be helping me out behind the scenes. We also want to thank McLean Hospital, who agreed to co-brand this presentation for us and agreed to promote it through their community as well. So if you have joined us having heard of it from the McLean Hospital in Boston, thank you so very much for joining us this evening. I would like to introduce our guests for this evening. We have Dr. Blaise Aguirre, who is MD. He is a child and adolescent psychiatrist, and he is the Michael Hollander PhD endowed director of the 3 East Continuum at McLean Hospital. That's a mouthful, Blaise. He's a trainer and specializes in dialectical behavior therapy, as well as other treatments for borderline personality disorder and associated conditions. And he is the founding medical director of the 3 East Continuum of Care. 3 East is an array of programs for teens that uses DBT to target self-endangering behaviors, as well as the symptoms of borderline personality traits. He has been a staff psychiatrist at McLean Hospital since 2000. He is nationally and internationally recognized for his extensive work in the treatment of mood and personality disorders in adolescents. Lectures regularly throughout the world and is the author or co-author of many books, including Borderline Personality Disorder in Adolescents, Mindfulness for Borderline Personality Disorder, Coping with BPD, Fighting Back, and DBT for Dummies. Some of these books he has co-authored with our other guest, Dr. Gillian Galen. So first of all, I'm going to hold up the book, DBT for Dummies, which is one of the more recent publications and is a really great resource for people just learning about DBT. So Dr. Gillian Galen, our other guest this evening, is the program director at the 3 East Girls Intensive and Step Down programs and director of training in the 3 East Continuum. So working together with Blaise there. She is a senior child adolescent psychologist, specializing in DBT. And so she has extensive experience diagnosing and treating adolescents and young adults who struggle with emotion dysregulation, anxiety, depression, trauma, and other self-endangering behaviors such as self-injury and suicide. Dr. Galen has a particular interest in the use of mindfulness in the treatment of borderline personality disorder and psychiatric illnesses, and she is also the co-author of several of those books and probably some of your own. So I don't want to read the same names all over again. But after all of that, I really personally want to thank Blaise and Gillian, both of you, for being here with us. I've had the pleasure of meeting you in the past and the pleasure of hosting presentations with you before, and I'm just absolutely so delighted to have you here with us again this evening for this very important conversation around how to talk about suicide. There's such huge stigma, and we're really, really interested in hearing what it is that you have to say for us this evening. So I will hand it over to you. Thank you.
Awesome. Brilliant. Yeah, so welcome everybody. Lynn does it again. Whenever I give like nighttime talks, I have like 3 people show up, Gillian and maybe one of my kids by mistake. But, you know, Lynn puts on an evening talk and she has more than 300 people. So just such a powerful voice for compassionate care, you know, and for dedication to people who suffer deeply. So one of the things that Lynn had asked and was you know that this be a little bit more of a conversation. So we're actually not going to be very slide heavy. We will make the slides available if you're interested, but mostly you know, we'll go over some facts, etc., and then we'll go over some myths about suicide. But we really want to have this be, you know, an open conversation, you know, and again, as with other sort of talks, you know, it's going to be very hard to answer very, very specific things about maybe your particular kid or a person that you care about. But we can definitely answer a lot of general types of questions or questions about what to do when, etc. So, all right. Is that right, Lynn? Yeah. All right. Excellent. Okay. All right. Okay. So, this is just I shared this just recently. This is a text that my son got. Dad, I just got a text from a girl in my school. She's been cutting herself because she didn't want to tell you because she knows you're a psychiatrist, but I feel like you might be able to help her out. She doesn't have to be like an official patient or whatever, but I'm pretty sure she's pretty close to making things a lot more serious because she's been cutting. Now, the reason this text struck me for many reasons. One, when I was a 15-year-old, one of the kids in our class died by suicide. And we only found out about it years later. I bumped into the dad and, I said, oh, like, how's the other? We thought he'd gone to another school. And they told us that the kid had taken his life. And so that's one situation where we knew nothing about the kid's mental health. We found out years later. In this situation, with social media and texting and smartphones, everybody knows so much about so many things. And my son came and talked to me about this particular situation. And the truth of the matter is, and this is just another little statistic that was reported in the Wall Street Journal, that in Massachusetts a couple of weeks ago, there were 800 young people waiting in emergency rooms for mental health care, and there was absolutely nowhere to put them. And it's pretty traumatic to be a kid in an emergency room and waiting there for weeks. So we're seeing this increase in despair. So let's just go through some of the quick facts. Youth and young people, account for 14% of all suicides. Interestingly, and that the suicide rate is lower for this group than for other groups. However, it is the third leading cause of death for young people, accounting for more than 6,000. These are US data, but I was looking at the Canadian data, and they're not that different from the US data. For youth ages 10 to 14, it's the second leading cause of death. I mean, it's remarkable to think that a 10 to 14-year-old child can even contemplate this idea of death by suicide. Boys are more likely to die by suicide than girls. Girls are more likely to attempt, and that guns are involved. That in other countries that are less developed, obviously there is suicide, but the fewer guns, the fewer. It stands to reason the fewer deaths by suicide by gun, but there's also fewer deaths as a percentage by suicide. This was remarkable that in 2019, about 10% of high school students reported attempting suicide during the previous 10 months. I mean, I had to reread the statistic just to make sure that I was getting it right. Because I go to like a high school football game or soccer game or whatever, and I look around and maybe there's, 200 kids. To think that 20 in the last previous 12 months have attempted a suicide. The attempts were most frequently reported among girls compared to boys, among non-Hispanic American, Indian and Alaskan Native students. And this again was also true in Canadian data. I was going to look at data in other countries, but I thought, because most attendees are in North America, the USA, and Canada, that I would just stick with these data. But but there's no question that young people are contemplating suicide all around the world. The other part, because I think that this is a very key discussion point, is this idea. When my son showed me the text, it was this idea of self-injury, and we thought it important to discuss non-suicidal self-injury in this context because it is very, very prevalent. And even though it is not suicide, and it's not suicidal behavior, the vast majority of self-injury is not suicide. There's a very strong association between self-injury by cutting and suicidal behavior. The overlap between non-suicidal self-injury, which is another word for cutting, and suicidal behavior is approximately 70% in clinical population. So in other words, of people who are suicidal, about 70% will have self-injured. But in non-clinical populations, I mean, people who never show up, who are just assessed by researchers, there's about a 50% overlap. The risk of both suicide attempts and suicide is significantly higher in those who've engaged in cutting. Of those with a history of cutting, about 70% have attempted suicide at least once, and 55% several times. And then people who self-harm are about 30 to 50 times more likely to die by suicide, depending on the level of cutting. So, if somebody has self-injured once, their risk is not that much higher than the average population. But the more self-injury, the more likely they are to die by suicide, even though every single one of those self-injury attempts, in the vast majority of cases, is not a suicide attempt. And one of the things that we urge our clinicians is that, if somebody's self-injuring, you always have to really assess what their intent is, because yes, it is true that the vast majority of people who self-injure are not trying to make a suicide attempt, but it can happen, and there is a risk, an increased risk of dying by suicide. So the clinician always has to be on top of this question: is has the shape of suicide, of self-injury, changed in the sense of is it more intense? Is it more paired with suicidal thinking? Is it happening more frequently, etc.? Okay. In the US, there was approximately, in this younger age group, 10 to 14, there was, nearly 250,000 emergency room visits for self-harm. Young girls and young women are at particular high risk, nearly 500 per 100,000, and twice the rate of emergency department visits as among boys and young men. But perhaps more concerning is that the rate of emergency department visits has doubled compared to 2001. What's interesting is that even though admissions to emergency departments has remained pretty stable over the years for young boys and girls, it has more than doubled when it comes to self-injury. So in other words, if somebody goes for a flu or for a stomach ache or headaches or whatever it is, that has remained pretty stable, admission to emergency departments, but for self-injury and mental health, it's gone up. Now, a couple of particular things, and that is, we are seeing being referred many more sexual minority youth, and on average, they're about 3 times more likely to present with suicidality than their heterosexual peers. The other thing is, Gillian and I were talking about this, is that in the early years when we were at McLean Hospital, we used to see some transgender youth, but not that many, or certainly not many who said that they were either gender dysphoric or considered themselves transgender. We have seen a remarkable spike in transgender youth over the last year or two. And it's hard to understand the phenomenon, whether they feel more comfortable, whether it's part of typical adolescent development where they're questioning who they are, And then there's people who identify as transgender who are very gender dysphoric. They really are unhappy in their bodies, and others who don't seem to worry too much, and seem to want to identify with their peers. And it's hard to sort of tease out this group exactly, but 65% of the transgender youth seriously considered suicide in the past year. And if you think about earlier on, I gave the statistic of about 9% of kids had made a suicide attempt in the past 12 months. Now 65% transgender youth. Now that doesn't mean that they made a serious suicide attempt, but they've seriously considered suicide. This is just another statistics that there are nearly 2 times as many suicides in the United States as homicides. And one of the big themes in the election was the theme of crime and the theme of homicide. And yet we've got this pandemic, which is, people talk about all the support that we need to reduce homicide and crime, which we 100% should. But I wish that there were that kind of attention paid to suicide, because there's nearly 2 times more people who die by suicide. Just getting back to this, to the gender minority, it's interesting that family rejection of a child of non-binary status increases the child's suicide risk, and more than 40% of kids report we'll have to change that, who live in a non-affirming family report a suicide attempt. But here a really remarkable thing happens. When a family either decides they're not going to fight with their adolescent, or they're going to just simply affirm that the child is questioning, struggling, identifying as trans, simply the act of affirming reduces suicide attempts by 50%. And that doesn't mean that you're out of the woods, but it means that you're at least at a place where you can start having a discussion. And a big part of this is the sense of belongingness. We know that one of the biggest risk factors in all of suicide is aloneness, loneliness, feeling disconnected from. And for many of these kids, whether they feel that they don't belong to their family, whether they feel they don't belong to their school, can really impact this experience of alienation. Okay, and the other thing is this, and I was sitting this morning. I was on a show, a big network, and we're talking about mental health. And this mom was telling me that her son had died from a drug overdose, and she very understandably teared up. She said that my kid, suicide was tragic. Her kid had died from a drug overdose, and it just got me thinking that you lose a child, and and you think, oh well, okay, I can check off the box suicide, or I can check off the box overdose, but you've lost a child. And that whatever was going on in that kid's life, whether it was death by suicide or such a big overdose, that there was a despair that was going on in the kid. And there was an interesting statistic that said that the rate of overdose deaths in the US, even though it had nearly doubled in 2020, but that it's remained somewhat stable over the last couple of years. However, suicide deaths from overdose have skyrocketed, and the total amount of deaths in young people from either overdose or suicide. And again, I don't want to say that these two things are the same, but I'm just saying that you've lost a child, to often a child who is suffering with severe emotional pain. And again, that whether it's by suicide or overdose, that these are deaths of despair, and that we need to pay attention to. Okay, so I wanted to just get onto and have those kind of early statements, just to kind of contextualize what we're talking about, and then I'm going to pass it on to Gillian, because we're going to talk about some of the myths that we hear. And by the way, these myths that we hear are not only from parents, or from schools, but they're also from colleagues. And I remember, Lynn, the very first time you had me up at the school, when we did the school circuit, people were very, very worried about the very first myth. And I remember we talked a lot about it. So I'm going to pass this on to Gillian. Gillian, let me see, where am I? So I'm gonna mute, and you can tell me when it's the next slide. So.
All right. So talking about suicide is hard. People often have a lot of fear around suicide. And I think these are really the common myths about suicide that really get in the way of communication. And what we know is that actually being able to talk about it, which certainly requires a level of emotion regulation within ourselves as parents or friends or caregivers, and the kids, whether they're adult children of ours or they could be friends. But these are things that get in the way. And hopefully by the end of these slides, you're going to feel a little bit more confident in identifying the myths and really thinking through not only what gets in the way of talking about, but some of the benefits that actually can come from having these really, really challenging and often painful conversations. Okay, so the first myth is that you can't talk about it. Like you can't talk about suicide. And this is a message in a lot of communities that we get from a very young age, that there are certain things we don't talk about, and it's not talked about in families, it's not talked about in schools. Now I think more recently, people are beginning to start to figure out how to talk to people about this, and particularly with the fact that actually, the group that is most at risk, the group that the rate of suicide has gone up about 300% is that age 10 to 14-year-old group. So we actually do have to start talking about this young. So can you go back, please? Okay. So you can't talk about it. So the fact is that actually talking about suicide is an opportunity for communication, okay? Sometimes the scariest thing for parents is when kids' behaviors and experiences go underground. We can't see them, right? We know they're suffering, or maybe we don't even know they're suffering, right? Because they're not sharing it with us and we're not asking about it, okay? So there is a commonly held perception that actually inquiring about suicidality, and sometimes this is in research and sometimes this is with therapists, can increase suicidal tendencies, sort of this idea of like, I don't want to plant something in their mind, right? Maybe if I say something about it, then they'll think about something they weren't thinking about before. And it's really the opposite, right? People that think about suicide think about it a lot, okay? They don't have it necessarily planted in their mind when somebody that cares about them or is concerned about them talks to them about it. Okay, usually people have thought about it for quite some time. And, they're hearing about it from peers or in books or on movies. But simply talking about suicide, it is very, very, very unlikely that you are going to plant this idea in somebody's mind when it hasn't already been there.
And, one of the things is that if you say, okay, well, then is the opposite true, that you can talk about it, but then, I can imagine myself as a parent having my kid come and tell me that they've had these kinds of thoughts, and because kids are so sensitive, especially sensitive kids are sensitive, they pick up on your level of fear and distress, and to Gillian's point. The concern is that the behavior then begins to go underground, and they don't talk about it, so they suffer alone. So it's not that to Gillian said earlier, it's very difficult to either hear or listen to or talk about, and this is where I think parents also need support just in knowing what to do in the event that they have this discussion with their kids and their kids share that they're suicidal. So, okay.
Okay, the next myth. If kids or people in our life talk about suicide, they won't do it. Okay, so on one side we're saying have the conversation, right? But if people are saying that they are suicidal, they're usually serious. Okay, and so just talking about it doesn't mean that it's attention seeking, which I think is probably one of the most common feelings that people sometimes have. Right. And the fact is that actually talking about suicide, right, is often a way that people are asking for help. We suggest taking it seriously, right? So we may have judgments, there may be past, indications or signs that maybe they weren't always serious. We take suicide and talk about suicide very seriously. Those people that are most at risk will often show signs of distress. So we're going to help you kind of think about some of those signs. And what we want to do is encourage people to talk more, and then we help them find, what kinds of support or assistance they might need, right? So these are some of the things that you can ask in a very sort of curious stance, which is, you can ask them, is this something they're considering doing, right? Sometimes people have thoughts of it, sort of fleeting thoughts. Some people have sticky thoughts. Some people, they just stay as thoughts. Sometimes they move into what we call more suicide planning, right? And then from the planning, it moves into figuring out the means that they need to use, okay? So each one of those is becoming more and more and more serious. Then they may plan what they're going to do, how they're going to use, what they're going to use, and when they're going to do it, okay? So you want to ask them if they have a plan. Right? You don't want to trivialize the plan, right? Even if it's not dangerous. Okay. So many people will make suicide attempts and then sort of they go through with it and then somebody labels it as a suicidal gesture, right? For example, they took, too few of some sort of pill to actually, cause too much harm. They took 5 Advil, right? Or they took too much melatonin, okay? But we take this seriously, even though the plan maybe wasn't dangerous, right? This is a sign that things are going in the wrong direction, right? And so, we are grateful that the plan wasn't a lethal one, right? And all of these behaviors are serious because they can evolve, okay? And what we know is the more people practice suicide, right, or engage in planning and thinking about the behavior, the more at risk they are for completing suicide, okay? So if somebody is actively suicidal, call 911, go to the emergency room, unless you are working with, for example, a DBT therapist that may have a very specific plan to try to keep them out of the hospital, but everybody is working together around these times when suicidal thinking and, potentially moving towards behaviors rises. So the next myth is that suicide happens without warning. Okay, so the fact is the vast majority of young people who are struggling with suicide are at risk for suicide, and they show the following signs. This does not mean that there are not certain people, and I think we see this all the time, where people say like, I didn't see any signs, okay? The question is, did they not see any signs or did they not know what to look for, okay? So here are some of the signs that you want to think about, okay? So there can be, people that have had a recent loss of somebody that they loved, of a friend or a relative from death by suicide are at much higher rates. Okay, we often will see this in school systems, and sometimes it's labeled a contagion effect. Okay, and it's not necessarily this idea, they're just copying one another. There really is something that puts people at much, much more risk. And so sometimes in school systems, you'll have one tragic death by suicide, and then very shortly after, there'll be another student that will die by suicide, okay? People that have made suicide attempts before or have active self-injury are at higher risk for making suicide attempts. If they express suicidal thoughts, okay? People that have had long-standing depression that isn't lifting, people that have trauma and PTSD and substance use, okay? And if any of these are paired together, that increases people's risk. Expressions of self-loathing or feeling like a failure, right? Or not sort of being able to think about the future. Or actually, what's interesting is a sudden increase in energy, right? Saying that they're okay very, very rapidly after they have been quite depressed. Okay. Those are other things that make people at risk. Also, the 2 weeks following an inpatient hospitalization for a suicide attempt or something related to suicide, you are at greater risk also in that 2-week window following discharge to make a suicide attempt. Okay, the age of onset matters, right? So how often the brain gets caught thinking sort of these grooves of self-harm thoughts. So the lower age of self-harm onset, right? And the longer they've been doing it. So it's not somebody that's just sort of, even though they might be young, say at age 11 or 14, start self-harming. It's the combination of starting young, right? And continuing for a long period of time are actually at higher risk. And that there's an increase in repeated suicide attempts when the age of onset of self-harm decreases and the duration increases, okay? And dramatically more for long duration of self-injury before the first suicide attempt, right? So for those of you that are familiar with or practicing or part of a DBT group, you will know that we actually target life-threatening behaviors, which is suicide and self-injury. So even though non-suicidal self-injury is not really the goal, is hardly ever to kill themselves, it is highly, highly associated with risk for suicidal behaviors and attempts. And so we look at them very closely together, like Blaise was talking about. So this is a myth, and this is one that, you know, particularly if you have a loved one that's struggling with emotion dysregulation or borderline personality disorder, this does show up. It's just attention seeking, okay? So we take suicide, as we talked about, very seriously. All suicide attempts must be treated as though the person has intent to die and must always be treated seriously, okay? And again, the more burned out we may feel, the more exhausted we may be as we're along this journey with a loved one, the higher risk we are at falling into these judgments of, oh, it's just attention seeking, right? It's just manipulative, right? We use those judgments and actually missing some really significant signs, okay? If it is attention seeking, if you're working with those kinds of thoughts and judgments, the key is to ask yourself, what are they seeking attention for, right? If they're not truly suicidal, right? And are there ways that we can help, you know, could be adolescents, it could be adults, ask for what they need, okay? So sometimes, right, suicidal behaviors have been reinforced as a way to engage people around us. But we need to not judge and ignore it. We need to ask ourselves, okay, what are they communicating, right? And what are all of us missing, okay? Because even though it may be a way to communicate, it's a very, very risky way, okay? So dismissing suicidal behaviors as manipulations is dangerous, okay? It makes us blind to people's experience and their risk, okay? And we also know that the function is actually rarely attention-seeking, right? Often when you ask people, they have been struggling with suicide and suicidal thoughts and behaviors way, 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 much, much longer than we ever knew about. So myth, teenagers and college students are the most at risk for suicide. Okay, so here's the fact. The suicide rate for this age group is below the national average, right? And actually the suicide risk increases with age. Okay, so the age group actually with the highest rate of suicide in the US is men and women between 45 and 64. Okay, though there are particular groups that may be at higher risk, right? So we've talked about some sexual minorities. We've got another group of 10 to 14-year-olds that it becomes rapidly increasing. So we're going to watch that group. It is true that younger people are more likely to have suicidal thoughts and self-injury, right? But as a total percentage of death by suicide is actually higher in that middle-aged adult group. All right. So we wanted to leave a lot of time for questions and have some discussion, because this is not something people like to talk about. It tends to be something that people are very uncomfortable talking about. So we want to give people an opportunity. Blaise, we can see your sashbear.org, but not your face.
No, I know. I'm doing that on purpose. I'm
Okay.
highlighting Sashbear.
All right, highlight away. So maybe Doreen, can you help us filter through the questions that you think would be most helpful, or the ones that are maybe repeated a lot?
Absolutely. And I know now that we have started to address questions, there will be many more come in. But I'll say one of the first things is that a lot of families are mentioning that they contact 911 or take a child to emergency, and that then becomes quite re-traumatizing. And so then there's a lot more resistance, plus they're not getting a lot of help out of those situations. So how do family members navigate through that sort of catch-22 situation?
Blaise, do you want to tackle this one?
Sure. Yeah, I mean, when the system is calm and they can take kids in, that's one thing. But I think that similarly, probably to what you're seeing, you're calling 911, you get re-traumatized by the system. We've had situations where EMTs or emergency medical technicians or police come in, and they take a bit of a heavy hand. So just a couple of things that to recommend. One thing, as a general rule, the more psychoeducation you can do for everybody in the community, including police, including ambulance people, including EMTs, and especially if your kid is somebody who maybe struggles, just to have some psychoeducation, because the police are just as prone as everybody else to say, oh, this kid is acting up, this kid is having is attention seeking, etc., and take a bit of a heavy hand. So that's one thing. But the other thing is the more educated a parent is, the more they're able to manage on their own. Now, of course, if somebody's made a significant suicide attempt, if somebody's taken a large overdose or done something very serious, you have to get them to the emergency department. There's nothing that you can do about it. But what happens, especially with the kinds of kids that we see, is that emotional dysregulation begets emotional dysregulation. And so the child might say, oh, I'm really suicidal. The parent starts to freak out, understandably, that they're very upset. But then, which then dysregulates the child, dysregulates the parent. And by the end, it becomes much more of a crisis. So sort of having understood the warning signs, to be able to sit with a kid and say, you know what, I hear you. Let's tell me what's going on. And, for many people, especially the kinds of kids that we see, that suicidal crisis peaks and drops. So they might have suicidal ideation, but then typically it's triggered by some event. It peaks, and then it drops. Now, it would be wonderful if everybody could have a DBT therapist, but programs like Sashbear that do a lot of parent teaching will teach parents how to regulate themselves, be able to have discussions with their kids. And I just think that at times, and as hard as this might be to imagine, being able to deal with this at home with your child is actually going to be less traumatizing, more collaborative, more problem solving, and have better outcomes than if you send your kid to emergency. But I mean, if there's any doubt, one should send their kid to emergency. So those are just some thoughts. I don't know, Gillian, do you have other thoughts?
Yeah, I mean, I think I have so much compassion for the cycle that everybody gets caught in, because, inpatient, like emergency rooms and inpatient hospitals, they don't do treatment, right? So you go in and you wait however long you wait, hopefully you go in quickly. Sometimes you wait a week. Certainly in the US, it depends when you land there. And then you go into a hospital where they change your environment and they keep you safe, but they don't necessarily teach people or support people or give them treatment. They stabilize people. So it's, if you're having a hard time, right, accessing the care that you need outside, it can be very re-traumatizing because it can feel like you're just, out for a little bit and then you're back in, and then you're out for a little bit and you're back in, which can actually lead to hopelessness within a whole family system. So I think I think it's doing the best that you can to figure out in your community what treaters and what providers are comfortable treating people that have suicidal thoughts, because many are not. And like Blaise said, really learning, reading books, if you can find a family connections group to join, if you can get to these kinds of webinars so that you can learn, what you can do and also what support you need. Because I think these are the kinds of experiences that burn parents out, and parents get isolated and depleted. So parents also really need to take care of themselves, which can feel very antithetical. How can I do that when my child is suffering? The best thing you can do for your child is to take care of yourself. But often you need to be around a group of people that give you permission to do so.
Mm-hmm. I want to follow up on that. And if you're in a situation where, and I'm seeing this in some of the questions, and this has been my personal experience as well, where your loved one has been hospitalized, or you're actually already at ER and they're simply refusing treatment, or they're being discharged from the hospital while the person is still saying, I'm actively suicidal. As soon as I get out these doors, I am going to go make an attempt. How does a family member, I think family members feel that they're being left on their own with this, and that the providers are not taking that seriously.
Yeah.
And you're in that situation in the moment, right?
Right.
Trying to get help.
Yeah, and I mean, we see this. I mean, because our hospitals are full, that it's unfortunately, it's like I heard one kid tell me, she said, I've been having more suicidal thoughts, but maybe if I do X, Y, Z, then they'll take me seriously. And sort of, it's really a tragic idea that there has to be this elevation of behaviors in order to be taken seriously. And at the same time, you sort of think, okay, where are you going to put that kid? Because what happens was, like for a lot of the kids, certainly in Massachusetts, and I understand this also a problem, that they stay in the emergency rooms. They're housed on, medical wards, cancer wards, other kinds of wards that have nothing to do with mental health. Now here's the thing: is I used to be somewhat, when people said to me, oh, I don't want help. The truth is, I've actually, when I dig deeply into that question, I don't want help, it actually turns out to not to be so accurate. But what happens is that, if you say, I have a headache, and I say, okay, you know what, I'm sorry you have a headache, here's some nice hand cream. So you take the hand cream and you go home. And then you come back and say, look, that was a very nice hand cream, but I still have a headache. And I say, okay, well, why don't you do a flamenco dance? So you do the flamenco dance, you go home, come back and say, well, I've still got a headache. So the thing is that when people have experienced not being helped, they become skeptical and they become hopeless. And they say, I don't want help because everything I have done hasn't helped me up until this point. But when people start receiving compassionate care, thoughtful care, you actually see people start to engage because they can see things start to shift. Oh, this begins to make a lot more sense to me. But let me just say, in the height of emotional dysregulation, one of the things that we see is people say the meanest things they can possibly say. You're a terrible parent, you're a horrible parent, I never wanted you in the first place, I don't want care, my life is useless. That is often a manifestation of emotion mind. And one of the things that I do is I just recognize that someone is suffering. And I say, look, you're suffering. And you're suffering so much that right now, this is what you're thinking about. We can actually get through this. But then you can say, okay, well, that sounds really great, but we don't have that many people who understand about suicide. So who is that therapist who's going to take that kid? What is the system that's going to take that kid? And there is a patron saint of Toronto. I don't know if you know her, Lynn Curry, who is just like a wonderful human being who has insisted on increasing awareness, increasing training in people who don't understand it, because you're not going to be able to get every single mental health specialist who should actually be trained in suicide understanding and awareness. So it's also sort of training the parents. But I do think that this idea of most people become hopeless when they think, I've been down this road 16 times before. Everybody tells me that they're going to help. It doesn't help. I don't want help. What they're saying is, I don't want help that doesn't work. They're not saying I don't want help, period. They don't want to suffer. People who are suicidal do not want to suffer. It's not a choice that they have, but they don't, everything that they've tried hasn't worked. So it is re-engaging with that side of them that recognizes that. Gillian, I don't know if you have any other wisdom.
Yeah, I think there's nothing, I think, more scary for a parent than the child that doesn't, and it could be an adult child, that does not want to get help. And that, maybe there's not perfect help, but their message is, I'm not doing it, I'm not going, I'm not speaking, I'm not participating. And I think we get really scared. And then I think what's interesting is that we have now joined them in an emotion mind. And sometimes we stay at fear, a lot of time we go to anger, right? And we inadvertently do the very things that create additional suffering for everybody, right? So, I can't emphasize enough, it's that validation and that curiosity. I think as we get more afraid, you're going to treatment, you're doing this, and they say, I'm not. And then you say, no, you are doing this, and we're going to, take everything away or make everything harder, or, and we do this out of our own fear, right? So I can't emphasize enough, when we find ourselves in those places, to recognize that our fear makes a lot of sense, right? And to stay curious, maybe they won't speak to you about it, but we can do it for ourselves. What might they be afraid of, right? What might make them want to take this position? Then we come with a much more compassionate position to ourselves and to the other person. We're much more likely to understand this and eventually get them to work with us. It's when we lead, when our own emotion mind gets going and we lead with our anger and frustration, which makes sense. But if we lead more with our fear and our compassion, then everybody starts to understand one another's suffering a little better. We have a better chance of moving forward in some direction, right? And maybe understanding that it's not that I don't want help. It's that everybody has said, I'm going to help you, and nothing is working. Okay. So now we understand the problem, right?
Thank you. For me, that's really helpful. And I know a number of the questioners have mentioned this idea of fear, and I've certainly experienced that. And to be reminded that fear turns to anger quite often, and we can get trapped in the fear, and we can then turn it to anger, and anger towards the person. But also in my case, a lot of times it was anger towards the system that wasn't offering me any help, right? But again, wherever it's turning, it's still not effective. So what you're telling me is to stay within that compassion, curiosity, keep the conversation open. That's a more effective and wiser place to be.
And it's a much harder place to be. Right? It's because it really asks ourselves to really do a lot of emotion regulation in a time where we're probably at our highest level of distress, right? Which is why we always say parents need support. Very hard to do this on your own.
It is very hard. Blaise, you look like you want to say something.
No. I was one of the things that happened. Some questions were popping up, and my mind was just like jumping to. Okay. I was thinking, oh, that's interesting.
They are all interesting. If
there's
any you would like to jump in and answer, go ahead.
No. I actually like that you're kind of reviewing them, because I think you're seeing many more of them, and certainly if there's a theme, we'd like to stay with that.
Yeah. So then to return to and keep in this theme of, this sort of cycle that families end up in of seeking help, and at what point does a family member simply say, we have tried everything we can, right? We've put treatments in front of this person. They have engaged in some treatments. They've tried medications, and nothing seems to have clicked, and they're still talking about suicide. Is that a point of acceptance that a family member should reach, or should we continue trying? Is there a conversation that we can have at that point?
This is a very, very difficult question from my perspective, because if somebody comes to me and I'm working with a suicidal kid, I will do everything I can that is in my power to prevent that from happening. But I see families who are exhausted, medications that haven't worked, therapy that hasn't worked. And, you know, I often have this thought in my head. I mean, if I were to take some of the worst and the darkest days of my life and say, here's what I guarantee, for eternity, that is going to be your life. I can understand why suicide would make sense. I can understand why somebody would suffer so much that they just would not want to be around. But so that's on the one hand. So what I'm saying is that if a kid has been suffering, or a young adult, for years, and it just like nothing seems to be making things better, I can understand why people would become hopeless. At the same time, I'm never going to give up on that person, because the vast majority of young people who come to us with suicidal thinking and suicidal feelings are able to live lives worth living, one. Two is this, and that I am very excited. I think that psychiatry, psychopharmacology has been stuck for many years with certain classes of drugs, tricyclic antidepressants, serotonin reuptake inhibitors, and norepinephrine reuptake inhibitors. There are drugs like ketamine. There are drugs like there's psilocybin, some of the psychedelics. There are powerful new TMS treatments and other things that do seem to be making a difference in some of the hardest to treat people. So I'm always hopeful that there's going to be something that is going to change a person's experience. And the other thing is this. One of the things that I discovered, sadly, knowing Lynn and her experience, is just the impact of comorbidity in certain kids. So that, I wish I had understood trauma a lot more, because what Sasha went through was so traumatic. But the impact on her was even worse, because she just suffered so incredibly much. Yeah, maybe there's BPD, but she had severe PTSD as well. So I think it's always to ask yourself, wait a second, we've tried everything. We've gone to all the DBT classes. Are we missing something else? Is there a learning disability? Is there OCD? Is there PTSD? Is there substance use? Is there an eating disorder? Is there something else going on? And I think, to be able to think about some of those other things as well. But it is very, very difficult when it's a person who's been suffering for a long time. So, Gillian, if you have other thoughts.
No, I think it's just very hard. I think it's that balance between, we can do everything we can to get in the way and prevent, people from engaging in certain behaviors. And at the same time, we can't prevent suicide. Right. So it's really, and I think, and this is something that people really have a hard time talking about, is that if we can actually radically accept and sit with that fear of we can't prevent it, then that interestingly actually makes us much more effective in doing, so if I can't prevent it, what can I do? And then we start being able to parent and intervene less driven by fear and desperation, and more about what can I do right now? Like, what do I need to do? How curious can I be? What treatments haven't I tried? What have I missed? right? Maybe there is, maybe we're not focusing enough on, the impact that having this learning disability and being pulled out of a class has had, right? What can we do? And I think it's a very, very hard balance, but when you can navigate that acceptance, you can become much more, I think, effective in actually intervening, which is exactly what we want, because we have the fear, but we're not driven by the fear. Doreen, there was
That's beautiful.
there was a question that shot across or popped up. It didn't go across, it popped up. Can I tackle it? Because I think it is, it's a myth, and it was a brilliant question, and maybe it came before and I didn't see it, but somebody said about burdening their child. I don't want to share my fear or I can't remember because I can't see it, sadness, my feelings with my child because I don't want to further burden them. So most people that struggle with suicide are emotionally sensitive. Okay. So as long as we're able to regulate our feelings, we're not sort of dumping our feelings on our child and asking them to fix them, right? Make me feel better. Kids know that parents are afraid, and kids know that parents are sad. And that actually is helpful for kids, right? Because they think if you don't share that with him, again, in a thoughtful, compassionate, regulated way that demonstrates skill use, that you're managing your own feelings, right? Then it feels right to kids. My parents love me. And of course, those feelings make sense, right? If I was my parents, I think I would be sad and scared too. Now, if my parents aren't sad and scared, right, because they look fine, right, they're not sharing that with me, then what does that mean? That actually becomes more confusing to your child, right? Because it sends the message of either one or two things. Either my parents are lying to me about how they feel, right? And why wouldn't they trust me with being able to sort of manage that, right? Or me as the child, I must be crazy because I really feel like my parents are afraid and I really feel like they're sad, but they're telling me that they're fine, right? So now I start feeling kind of crazy. So, I think we burden other people when we kind of dump our emotions on them and we ask them to regulate us, like, please make me feel better, please reassure me, when we can simply say, I'm really sad that you're suffering, right? I get really afraid when you make suicide attempts. Then we're just being honest. And it makes sense to the kids. They may not like it, right? They might say, oh, I hate I hate that what I do makes you feel sad. Okay. But that's when people that we care about suffer, right? People that care about us also have feelings about it. Okay. And then that's something we can navigate together. So, remember that, keeping many of the kids that Blaise and I have seen over the years find it very, very confusing when parents don't share anything about their emotional experience, and at the same time feel very overwhelmed when parents are dysregulated with their experience. So you need to, I'd recommend for people to really think about that and how do you share how you feel in an honest, compassionate, and effective way, and also show the kids, look, I can manage this. These are the skills that I use. Blaise, were you going to add to it, or are you just?
Yeah, no, that's exactly what I was going to say. It's not so much like, oh, okay, Blaise and Gillian said I should go and tell my kids how stressed I am and go in there and dump all your problems on your kid. It's sort of saying, you know what, I do get really sad. And this is what I do. So what you want to do is you want to model. So, yeah.
So open expression of our own feelings at the level that's appropriate for the child, for the other person, I guess is if I could sum that up. Parents don't just feel fear and sadness. Some of us feel guilt as well, that we're not doing enough, or that what we've done isn't effective, that we feel like we're failing our kids. Do you have a magic bullet for that one?
Yes, I do.
Me too.
Well, here's
lots
the
of
thing.
magic bullets for these. Yeah.
Yeah. Well, but here's the thing. Let's just think a little bit about guilt. And So what is guilt? Guilt is looking at the past as if you had the knowledge of the present. So if you would have known that things could have been different, it's not that you woke up 5 years ago and said, I want to have a suicidal kid. I'm going to do everything I can to upset the kid. You behave the way that you behave, with compassion, with kindness, with irritation, with anger, with frustration, with everything a parent does. For highly sensitive kids, that doesn't work. For kids that aren't sensitive, they brush it off. And so you can spend a lot of time in guilt. But here's the thing. If you spend this moment in guilt, tomorrow you're going to look at this moment and you're going to feel guilty that you spent this moment in guilt. You will never get out of the cycle of guilt. So you have to start with the idea that no one intended to have a mentally ill child or a mentally ill loved one, that you did the best that you could. Start off with that idea that had you known differently, you would have done differently, but you didn't. Now maybe you do, but now is now, then is then. To think that, your 6-week-old should have been able to walk because you can walk now makes no sense. They don't have the skill set. So you didn't have the skill set there. And what's much more helpful to the kid is not to beat yourself up, but to be skillful. So, because otherwise you'll live in guilt for the rest of your life. You'll say, oh, we went to that great class, but now I feel guilty that I didn't do any of those things. So I'm going to be in guilt all the time. Okay, but then tomorrow I'm going to be in guilt that I was still very feeling guilty about everything. So you get caught in this trap of guilt. You didn't know better at the time. You say, well, I should have known better, but that's not a useful thing. Respond for me when I get upset. My daughter raising, my other kids are like, you idiot. Who cares? So it's very different. So I'm just saying, like, you did the best you could. What are you going to do now? Let's get on with it.
I also think, you're pretty glitchy, Blaise. You're kind of coming in and out. I mean, you're glitchy other times too, but your internet is glitchy. It's been a long day together.
If those of our audience didn't know that the two of you are good friends and work together, I think they maybe need that context for the way you're speaking to each other.
Gillian and I have known each other for more than half of our lives. So it's I know she looks like 15, but she's actually a little bit older.
She's old.
But anyway, she can say in 3 words what it takes me like a book to say. So,
well, I know there's more questions coming, but number one, I think that what we also need to remember is that regulated, accurate expression actually can give you a lot of information, right? So sometimes parents can say, I wish that I had known what was going on sooner. Right. And then sometimes your child will say, how could you have known? Right. Now, some kids will say, yes, you should have. Here's all the things that you missed. Right. And then it becomes a wonderful validation opportunity. Right. And other times you may have been carrying around this idea and feeling so guilty. And your child is like, you couldn't have known. I didn't know. I didn't tell you. I wasn't connected with how I felt. Right. And then again, those are moments of repair. So thinking about accurate, regulated expression can actually help in our relationships move forward, right? Instead of staying in our mind and making a lot of assumptions. And then the second thing that again popped up on my screen is absolutely many people are told to shut down their emotions and not show it to their children. Just shut yourself down and make sure that they know that, you're unaffected. I think what we know is, again, like Blaise said, some kids, that's not a problem. They can kind of figure it out. Emotionally sensitive kids, we have learned it is a problem. They get very, very, very confused, and they often will draw conclusions that really aren't in anybody's best interest. Like, maybe my parents don't care. Maybe they aren't aware. Maybe they're afraid to tell me. Maybe they think I can't handle it, and then it goes from there. So really thinking about sort of accurate, regulated expression of our emotions.
when we have a youth or a family member who starts to shut down and doesn't want to talk about it anymore, is there some guideline around how often you might ask, or how you would open up a conversation, or how much to press if you ask and the person says, no, I'm fine, or you ask if they're feeling suicidal because of a behavior, something has given you that thought, and they're like, oh, well, maybe, well, don't bother me, right? Like they're kind of off-putting and not really open. How do you proceed with a conversation in a way, or do you push or not?
Yeah, so great question. I mean, I think one of the things that adolescents are sick of, and young people, but I know that there are other people on this call who have adult children with suicide, maybe adult family members with suicidal behavior, but they're sick of the 20 questions. So one thing is to say, look, our goal is to keep you out of the hospital. Our goal is to keep you in the minimal amount of treatment so that you can get on with your life. And at the same time, suicidal concerns are, very, very serious. So I want to know when you're suffering. I want to know when you're suffering. If it's helpful for me to ask you, I can ask you. But it's not like, good morning, darling, are you suicidal? But I would think about it in the context, especially when you're seeing behavior that is a change from previous behavior. So the kid's gone to school 6 days in a row, and then on the 7th day, they had a fight with a friend and they want to stay home, and and they're looking lower. You say, look, I know that you've had suicidal thoughts in the past. Is that something that's happening for you right now? And the child might do one of three things. One, they might say, I'm really struggling with that, and have a conversation. Two, they might roll their eyes and say, like, you're making a big deal out of it. And you can just say, look, I maybe, and I want to be helpful, or like that they just don't want to talk about. And the one thing I say with that one is, depending on the behavior, but with suicide, this is very important from my perspective. Some things are okay to delay. Like they say, okay, I don't want to talk about the breakup with my loved one. You say, okay, you know what, why don't we talk about it when you feel that you can? But if it's around suicide, I don't give them, if they're cagey or evasive, I tend to take that seriously unless I know the person extremely well. Because getting it wrong, I mean, if somebody says they're going to get a tattoo of Donald Trump, well, okay, if you get it wrong, then they have a tattoo of Donald Trump. I mean, what are you going to do? But getting this question of suicide wrong, you could have a dead kid. So if they say they don't want to talk about it, you say, you know what, we don't have to talk about many other things. You don't even have to tell me what's leading to it, but I am worried about this, and will you let me know? And sometimes having the engagement with the kid around when they're going to share whatever they're going to share, they will be honest over time if they feel that they can have an honest discussion with you.
Another question that's come up quite a bit is how to talk to other family members, particularly siblings, when there's been a suicide attempt or a lot of suicidal ideation.
Yeah, I mean, I think this is a really complicated. This is a complicated question. I think if you want to tackle siblings first, this has a lot to do with age. How you can talk about these suicidal or self-injurious behaviors really depends on, how you do it, depends on how old the sibling is. And then you have the added challenge of, respecting the other child's privacy, right? So, how much do you share? I often will talk to parents about, have that conversation with the child who is struggling, and think with them about how much do you want to share? Do you want to share this? Is this something I can share? And I think that's usually sort of a springboard for parents to get a sense. And you know what? Many of the siblings have a sense of what's going on. Like they either have been really aware and paying attention, And you have to really be careful with siblings because they also get really scared. So we often talk about, the trauma and the PTSD that parents get from having children that engage in suicide and self-injury. We often forget that these siblings see a lot as well. So, I think in terms of sharing the details, I would start with the child that is struggling and talk with them really openly about, how are we going to talk about this, with your grandparents or with, aunts and uncles or close family friends, and how are we going to talk about this with, your younger or older sibling or siblings. That's really the place to start. And I think with siblings, siblings need a lot of validation. And I think one of the most protective things that parents can do for siblings is validate what their experience is. And I think one of the things that's really hard is when there is a child that is struggling with things like really severe emotion dysregulation and suicide and self-injury, they take more of our time and energy and emotional energy. And I think it can be very, very painful when parents realize it is uneven how much time I've been spending, or I had one parent say, my child's older sibling ate dinner alone 4 days a week for a year when we were running back and forth to therapy appointments or hospitalizations or, these things. And the most protective thing is to recognize how hard it has been for that sibling, maybe how unfair it's been, maybe how, what you've missed out on. And you'd actually be surprised that goes a really long way. What doesn't do well is justifications, because it's a very complicated experience for siblings. I've also worked with a lot of siblings, and many of them will say they always start with, you're not gonna believe what I'm gonna say, it's so terrible. And I sort of say, I think I'm gonna believe what you say, and I think it's not gonna be terrible at all. And they say things like, I'm really worried about them, and I'm really mad, that my parents have been gone for a year dealing with this, or I'm just tired of the chaos. I'm ready for this to be done, right? And I feel horrible because, of course, I love my sibling and I don't want them to suffer. So validation is the key with siblings, and really talking to the child that's struggling about having them help you figure out what information you're going to share and what information is going to be private. I don't know if you have anything to add, Blaise.
Okay, thank you. So we're at 8:14, and unfortunately, the time has flown past. A lot of the questions that are coming in are about asking for specific resources. So I would just like to let people know that in Canada, we are the Sashbear Foundation, and we offer the Family Connections program, which is a family program for family members of those who have emotion dysregulation, borderline personality disorder, suicidal tendencies. And it's for family members to learn DBT skills. And much of what Blaise and Gillian have mentioned today is touched on in those groups. If you are outside of Canada, the same program is offered through a US organization called NEABPD, or borderlinepersonalitydisorder.org is their website address. We can't offer any specific recommendations for therapists or so on, but certainly I think Blaise and Gillian, as DBT experts, would say that dialectical behavior therapy is pretty well what you would want to be looking for if someone is expressing a lot of suicidal ideation. And so that's, again, dialectical behavior therapy, or DBT for short. And certainly you can ask potential therapists and counselors if they have had exposure and training in that particular modality. The Family Connections program you can access through either sashbear.org if you're in Canada, or neabpd.org if you're in the United States or elsewhere in the world. I want to thank you both so much for being here tonight. And I apologize to everyone out there. I wish we could have gotten to all of the questions. If you had a specific question that we're able to answer and we have your name and email address from your registration, then we will try to get back to you with some information. And other than that, I think maybe I will just ask if Blaise or Gillian, if either of you have anything else that you wanted to add or close with.
Well, the only thing I was thinking about is because there were so many questions. I was wondering if maybe a future webinar could just be this, and that is, rather than even just a little talk on a specific subject, we would just say, send all your questions to Sashbear. And and let's just get the themes. And then what we could do is maybe even expand it a little bit longer, but then we could just say, okay, because there's often stuff that isn't addressed, like comorbidities or siblings or, and I mean, not that, again, we can't give very specific advice, but maybe it's like the questions that don't get covered in topics, like we cover validation a lot, we cover dialectics a lot, we cover suicide a lot, but there's a lot of questions that are important to families, but they don't, they're not fully addressed. So maybe what we do in some future one is we have no slides. And then we say, okay, these are the 20 questions that have come up, and then we dive deeply into those ones. But I leave that to the boss.
We will never say no to having you come back. I think Lynn will absolutely agree with me. Lynn is the boss. Or maybe you meant Gillian is the boss of you. I'm not sure, Blaise.
I think they tag team me. They come at me from different sides.
We'll make sure that Gillian and I team up, and then we'll have Blaise to come again. I just wanted to say, Blaise and Gillian, thank you so much for this conversation, like to share really your wisdom on with us tonight, like to really to create this platform to talk about suicide, because it's so important, and it's important that we remove that taboo, because we need to be able to speak about suicide. Because by not talking about it, like this is when, like you said, like when I look at the numbers, the data you showed us, like there's more people dying by suicide than being shot, and we need to address this, right? So thank you so much for being here. And yes, we'll book you again very soon.
Great. Thank you both. Before we have Blaise and Gillian back, we will have another professional speaking to us at the end of November. I believe it's November 30th, Dr. Wendy Bameter. Gillian, you can correct me if that's the incorrect pronunciation, Dr. Wendy Bameter. And she's going to be speaking on November 30th on sexual minority youth. So those who identify as lesbian, gay, or bisexual, and the invalidation that they experience and what we can do as family members to support them. She will be returning again in February to speak with us about gender non-conforming youth, transgender youth, and non-binary youth, and how we can support them. And so some of the statistics that Blaise showed at the beginning certainly emphasize the importance of that conversation. So please watch your emails for information about those presentations, and it looks like we'll have Blaise and Gillian back in the future. So thank you again for joining us this evening, and thank you, Blaise and Gillian, for being with us. Good night, everyone.